This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Hello, and welcome back. In the next two lectures, we'll be exploring Alzheimer's disease, the most common form of dementia. Remember that the term dementia refers to a group of symptoms associated with a decline in memory and other thinking skills that interfere with a person's daily functioning. In fact, according to the Alzheimer's Association, approximately 60 to 80% of all reported dementia cases have been attributed to Alzheimer's disease. Did you know that more than 5.8 million Americans have this disease? And that this number may increase to 13.8 million by the year 2050? Sadly, we have no cure for Alzheimer's, or even a way to halt its progression once somebody gets it. In today's lecture, we're going to go over signs and symptoms of Alzheimer's disease, the neuropathology of this disorder, how it is diagnosed, and associated risk factors. Then in this next lecture, we'll discuss preventative measures, pharmacological and non-pharmacological interventions, tips for helping people who have the disease, and associated research trends. Let's start with signs and symptoms. As it turns out, Alzheimer's patients will exhibit quite a wide range of these, affecting memory, language, attention and executive function, visuospatial abilities, sensation and perception, and mood and orientation. The effects on memory are perhaps the best known, so why don't we begin with those? We all forget things sometimes. We might forget where we put our keys or our reading glasses, or maybe we can't remember someone's name or what movie we recently watched. This is normal. It happens to all of us. But memory loss caused by Alzheimer's falls outside this normal range. Things like forgetting that we just ate lunch and then proceeding to eat again. Repeatedly asking a question we just learned the answer to. Or maybe even talking about someone who has died as though they were still alive. Here's an example. Years ago, I was testing an Alzheimer's patient for some research I was conducting through Boston University. As I was walking with this patient down the hallway, she turned to me and asked, "How old are you? You look like you're 16 years old." Given that I was in my 30s at the time, I was naturally flattered. I thanked her for thinking I was so young, then told her that I was actually 32 years old. About 10 seconds later, she looked at me again and asked, "How old are you? You look like you're 16 years old." Again, I explained to her that I was in fact 32. Wouldn't you know it, she proceeded to ask me that same question at least 20 times. Memory loss in Alzheimer's patients follows a temporal progression. So for example, if someone gets dementia at the age of 80, the first memories to go are those that developed at the age of 80, then 79, then 78, then 77, and so on. So the memories that are most intact are those that occurred decades earlier. Another symptom in Alzheimer's patients related to memory is difficulty completing familiar tasks. Of course, we all have trouble completing tasks sometimes. We might need help navigating the settings on our phone or computer, for example. But people with Alzheimer's disease might do things like get lost while driving to a familiar location, like the grocery store. Or they might forget the rules of a favorite game, like bridge. Patients may become confused about time and place. They might lose track of days, seasons, or just the general passage of time. Sure, We all forget dates now and then, including what day of the week it is. But this is different. The person might think it's morning when it's actually evening, or they might think the year is 1990 instead of 2022. Sometimes patients can forget where they are, or even how they got there. Another common memory symptom has to do with misplacing things and hoarding behavior. A person with Alzheimer's disease may put things in unusual places. They may even hoard items or collect them, and then accuse caregivers of stealing these items from them. This symptom reminds me of a patient I learned about back when I was in graduate school at Vanderbilt University. I was taking a class in neuroanatomy at the time, and one day we had a guest speaker, a woman whose husband was battling Alzheimer's disease. She told us that for the longest time, no one suspected anything was wrong with her husband. But that all changed one evening when they went out to dinner. They went to a restaurant that was serving a buffet. Her husband was behind her as they both walked through the buffet line. After selecting her food, the wife proceeded to sit down in a booth. Her husband joined her shortly thereafter. As he sat down, she looked over at his plate and was astonished to see that there was no food on it at all, though he had managed to collect all the serving spoons out of every dish served at that buffet. At that very moment, she knew that her husband had a problem. Now let's turn to symptoms associated with language. Patients with Alzheimer's disease will often struggle while trying to find the right word for something. For example, they might try to ask for coffee by telling you it is a hot black liquid that they drink every morning, but they just can't manage to say the word coffee. They may also call things by the wrong name. For example, calling a watch a hand clock. And they are likely to have trouble following a conversation. They may also stop in the middle of a conversation, either to repeat themselves or because they have no idea how to continue. Some patients may also experience problems with reading or writing. The next category of symptoms focuses on those that affect attention and executive function. You may notice that a person with Alzheimer's disease has a shorter attention span than they used to. Maybe they can't follow a conversation for very long, or they lose interest in things quickly. Patients with Alzheimer's disease will also have problems following a plan, even a basic recipe that they know by heart, or they'll have problems with numbers. They also may not be able to balance their checkbook anymore, or they may have difficulty paying their bills. And it might take them a lot longer to do things that they did more quickly before, even things as simple as getting dressed. Other symptoms in this category include changes in judgment or decision making, like making poor financial decisions, buying something they can't afford, for example, or maybe they give large amounts of money to telemarketers. Patients may also pay less attention to their own personal hygiene. The next category of symptoms that Alzheimer's patients face is that of visuospatial and sensation and perception problems. Recall that visuospatial abilities refer to the capacity to understand and remember how objects are spatially related to one another. Someone with these types of deficits may not be able to find their way from one location to another. They may also have problems reading maps or distinguishing left from right. Basic vision problems, especially in the perception domain, directly affect things like reading, judging distances, determining color, and seeing contrast. Remember back in lecture 3 when we talked about looking for a white electrical outlet against a black wall? Pretty easy, right? What if I made the electrical outlet black, so it was now a black electrical outlet against a black wall? It would be harder for you to find, wouldn't it? Well, an Alzheimer's patient might not find it at all because of their deficits in contrast perception. As it happens, most of my research directly relates to the problems patients with different disorders have seeing contrast. Let me tell you about a study I conducted with my colleagues Tracy Dunn and Alice Cronin-Gullum from Boston University and P.V. Cipollone from the Bedford VA Hospital in Massachusetts. Back in 2004, we published a research study that looked at how contrast affects eating behaviors in Alzheimer's patients. Why would we investigate this? Well, according to the scientific literature, caregivers often worry that their loved ones with Alzheimer's disease aren't eating enough. And this turns out to be a very legitimate concern. Even with a plate of food in front of them, many patients will only eat a minimal amount. But why? Is it related to their memory problems? Or could the issue be visual? Maybe they are having trouble seeing the food on their plates. You can't eat what you can't see. To find out, we observed patients at the Bedford VA Hospital, which has an inpatient unit for those with Alzheimer's. The nurses in this unit were, in fact, having trouble getting the Alzheimer's patients to eat. We noticed that the tableware they used consisted of white plates, white cups, and white table settings. So everything was white. Even the food itself was mostly white. Mashed potatoes, chicken breast, etc. We decided we'd try to find out if this lack of contrast between food and plate was preventing the patients from seeing and therefore eating their food. We began by establishing a baseline condition. For 10 days, we measured how much people ate at lunch and dinner. We did this by weighing the food on the plates once before it was served, and then again after mealtime was over. We asked the hospital's standard white plates during this time frame. For the next 10 days, we employed an intervention. We used bright red plates so that there was a lot of contrast between the plates and the food. Recall that the food was primarily white. Once again, we measured how much food the patients consumed at lunch and dinner by weighing their plates both before and after mealtime. For the last 10 days of the study, we went back to the white plates again and performed the same measurements. In this post-intervention condition, we reasoned that if patients showed an increase in food intake when the red plates were introduced, the effect should disappear when we go back to the white plates again. In other words, patients should eat the same amount of food that they did in the baseline condition. And guess what? That's exactly what we found. Food intake increased by 25% when we used the red plates, then returned to baseline levels when we brought back the white plates. What does this mean? It means that a major reason Alzheimer's patients aren't eating much on their plates is because they can't see the food. Next, we wondered if it made any difference what color the plates were or how bold the colors were. So we conducted a follow-up study, and it turned out that color itself didn't matter, but how bold it was made a tremendous difference. Basically, the more the food stood out from the plates, the more patients ate. I'm happy to report that several hospitals and adult day centers have adopted the simple strategy of using bold colored plates, and it appears to have helped their patients to eat more. The last category of Alzheimer's symptoms is related to mood and orientation. Patients with Alzheimer's disease may feel confused, anxious, depressed, suspicious, or even fearful. They're more likely to get upset easily when they're not in familiar surroundings, not knowing where they are or how they got there. They may also start to withdraw from work or social activities. They might have trouble keeping up with a favorite sports team or remembering how to engage in a favorite hobby like crocheting or woodworking. They may become less social over time, withdrawing from people they used to interact with regularly. So, those are some of the categories of symptoms associated with Alzheimer's disease. Every patient is different, though. Alzheimer's is actually a very heterogeneous disorder, and many of the symptoms I've mentioned can also be seen in other types of dementia. Now let's turn to what's actually going on in the brain of an Alzheimer's patient. Research shows that two hallmark features signal the presence of Alzheimer's disease: amyloid plaques and neurofibrillary tangles. Amyloid plaques are abnormal deposits of a protein fragment called beta amyloid, and they tend to develop between neighboring neurons in the brain, where they interfere with the neuron's ability to communicate with one another. So basically, amyloid plaques disrupt the signals that the brain is trying to send and receive. The second hallmark feature, neurofibrillary tangles, are caused by another protein called tau, which we've talked about elsewhere as well. Tau normally supports and stabilizes nerve cells. However, changes in its shape can cause tangles to develop. These tangles are found inside neurons, and they look like twisted strings. These neurofibrillary tangles will ultimately kill the neurons that they occupy. The accumulation of amyloid plaques and neurofibrillary tangles results in widespread atrophy of the brain. Basically, the brain shrinks dramatically. This atrophy then causes the symptoms associated with Alzheimer's disease. For example, damage to the frontal lobes of a brain will affect a patient's ability to pay attention, to make wise decisions, to balance a checkbook, or to act in socially appropriate ways. It might surprise you to learn that you probably have amyloid plaques and neurofibrillary tangles in your brain right now. We all develop plaques and tangles as we age. What sets normal aging apart from the development of Alzheimer's disease is the number of these plaques and tangles. In an Alzheimer's patient, the plaques and tangles develop rapidly. We currently don't understand why this is, but we think patients accumulate them before they even show their first symptom. The atrophy that develops is widespread and becomes more severe as the patient progresses through the various stages of dementia. Research by James Brewer and his colleagues at the UC San Diego School of Medicine has shown us how the atrophy caused by these plaques and tangles presents itself. Brewer and his team used MRIs to examine how areas in the brain change as a function of both normal aging and various disorders, like Alzheimer's disease. They found that different areas of the brain develop atrophy depending on the type of disorder the person has, and that patients with dementia exhibit excess levels of atrophy. Through their research, Brewer and his team basically created a database of these MRI scans that show the size of what different areas of the brain should be. Doctors can compare the scans of their own patients to this database to see what specific areas of the brain are damaged, and then use that information to help diagnose specific brain disorders. In addition to the overdevelopment of plaques and tangles, Alzheimer's disease decreases the production of a neurotransmitter called acetylcholine, which the brain uses to communicate with other neurons. Acetylcholine plays a role in learning and memory. So as you might imagine, decreases in this neurotransmitter are associated with memory problems. Drugs like Aricept work to increase levels of acetylcholine in the brain. The hope is that these drugs will improve the patient's memory function. But it doesn't work for everyone. And when it does, it sometimes stops working as the dementia progresses. I'm hoping that within the next decade, scientists discover why these changes in the brain take place. And more importantly, how we can prevent or stop these changes once they start. Alzheimer's disease is typically diagnosed through the process of elimination. If a patient is exhibiting possible symptoms, a primary care physician will perform a complete physical, order blood work, perhaps conduct a CT or MRI scan, and examine the patient's mental status, medications, and family history. Once other diagnoses have been eliminated, a diagnosis of probable Alzheimer's disease is given. Alzheimer's disease is typically only confirmed through autopsy by counting the number of plaques and tangles in the individual's brain. Risk factors for Alzheimer's have to do with genetics, physical condition, and age. Let's start with genetics. Two categories of genes influence whether or not a person will develop Alzheimer's: risk genes and deterministic genes. Risk genes increase the chances that someone will get the disease, though they do not guarantee it. Research shows that a risk gene known as ApoE gene is located on chromosome 19. This gene is associated with a more common late-onset form of Alzheimer's disease, which occurs in people aged 65 and older. The ApoE gene was discovered in 1993 and consists of 3 different types of alleles: E2, E3, and E4. We each get one of these 3 alleles from our mother and one from our father. So each of us has 2 ApoE alleles. Individuals who inherit 1 or 2 copies of the E4 allele have a greater risk of getting Alzheimer's disease than those who inherit the E2 or E3 varieties. Approximately 40 to 65% of people diagnosed with Alzheimer's disease have the E4 allele, but only 20 to 30% of people in the US as a whole have it. Remember, though, that we're talking about risk genes. So although having the E4 allele increases risk, it does not necessarily mean the disease will develop. Genes in the second category, called deterministic genes, directly cause the disease. So if you get one of these, you will get the disorder. However, deterministic genes only account for 1% or less of all Alzheimer's disease cases. These genes cause familial early onset forms of the disorder that develop in one's early 40s to mid-50s. 3 deterministic genes have been identified so far. Amyloid precursor protein, known as APP, was discovered in 1987 and is located on chromosome 21. The 2 other genes were discovered in 1995. Presenilin 1, or PS-1, located on chromosome 14, and presenilin 2, or PS-2, located on chromosome number 1. A former graduate student in our lab at Boston University, Dr. Yaquel Quiros, now directs the Multicultural Alzheimer's Prevention Program in Massachusetts. She and her team are currently studying the largest family in the world known to carry a presenilin-1 gene mutation, which leads to Alzheimer's disease before the age of 45. Their goal is to identify early biological and cognitive changes in people predisposed to developing Alzheimer's disease in the hopes of informing future clinical trials and early interventions. Besides genetics, other risk factors associated with Alzheimer's disease include conditions that are known to damage the heart and blood vessels, like heart disease, high blood pressure, high cholesterol, diabetes, and stroke. Individuals with one or more of these conditions are at a higher risk of getting Alzheimer's disease than people who do not have these conditions. Unsurprisingly, age is a risk factor as well. Most people who get Alzheimer's disease are 65 years of age and older. After the age of 65, a person's risk doubles every 5 years. After the age of 85, the risk jumps to 1/3. So the older you get, the greater your chances of getting Alzheimer's disease. Previous head injury is also a risk factor. Research has linked moderate to severe traumatic brain injury to the development of Alzheimer's disease later in life. Traumatic brain injury can cause increased levels of beta amyloid to be produced in the brain, as this protein plays an essential role in neural growth and repair. Remember, though, that a corrupted form of beta amyloid is associated with Alzheimer's disease. So it's possible that the release and accumulation of amyloid caused by a head injury sets the stage for later development of dementia. Disturbed sleep or lack of sleep is also a risk factor for Alzheimer's disease. It's estimated that approximately 40% of Alzheimer's patients suffer from sleep disturbances. Research suggests that patients experience shorter sleep duration times, fragmented sleep, altered circadian rest activity patterns, and elevated rates of sleep-disordered breathing compared to age-matched individuals without the disease. Finally, what about exposure to aluminum? Back in the 1970s, many people thought that using products that contained aluminum would increase your chances of getting Alzheimer's disease. Why did they think that? Well, as it turns out, if you examine the brain of an Alzheimer's patient upon autopsy, you might find higher than normal levels of aluminum. However, research has shown that exposure to aluminum is not a risk factor for Alzheimer's. Yes, there may be higher than normal levels of aluminum in the brains of some Alzheimer's patients, but no, this isn't because they used aluminum products. As it turns out, Alzheimer's disease causes a breakdown in the blood-brain barrier, the semi-permeable border that keeps substances from entering the brain. When this barrier breaks down, substances that normally could not pass through the barrier, like aluminum, are able to freely enter the brain. Thus, you might see higher than normal levels of this substance in the brain of an Alzheimer's patient. This concludes the first of our 2 lectures on Alzheimer's disease. In the next lecture, we'll continue our discussion by looking at ways to minimize our risk of getting the disease, potential interventions, practical tips for caregivers, and future research directions. Take care, and bye for now.